Good afternoon, everyone. So it's again a pleasure to have you all here. So yeah, so once again, definitely everyone. So it's a pleasure to have you all here in our the current student skill development program. And today is a very special day for us. Just a second. So some last minute technical glitch here. So today's thing is a very special thing for us because we are again having one more Padma Shri Awardee with us, Dr.Manjula Anagani. And she's a renowned obstetrician and gynecologist. She's an infertility specialist. And she is not a routine person who does IVF and does it. She has very unique skills where she does fertility reversal surgeries. And she has done her own innovations in multiple neovagina procedures and regenerative endometrium procedures and ovarian regeneration. She's also a pelvic urogyn and gynec oncologist. She's a clinical director and HOD of Care for Cellular Women and Child Institutes. Very known person, celebrity doc, friend of various actors and actors and sports person. So I don't want to waste much time because she has very limited time and she accepted for us request. And I believe our students will be the most beneficiary of this because we want to inspire our students by bringing in a lot of achievers and who are going to give us more insights beyond the subject. And we are going live on YouTube also. So thanks, madam. It's all yours.
Thank you, Dr. Natesh. I think the next generation is what will make the whole life much more easier for people. And let me first go to,
True.
Let me share. And the whole purpose of the whole thing is to make it simpler, life much more simpler and easier so that the treatment can be well within the reach with less using of thing, presenter view, right? Yeah, hi. So today I thought I'll just stick to the, apart from the regular routine thing, when Natesh asked me about what are you going to talk, madam, then I said, okay, there are advances in gynecology in various ways. So I thought, let me talk about the newer technique of neovagina and ovarian rejuvenation, how to rejuvenate. So this whole thing is about the regenerative medicine and the rejuvenation thing. So we are talking about three organs, the three things, tissues there. One is ovary, one is endometrium, one is vagina. So how to create a new vagina, or how to rejuvenate the ovary and how to regenerate the endometrium. This is what we are looking into. So whenever we come with newer things, first there's always a resistance when somebody has to take. So we need to understand what we are doing. We need to convince ourselves. Then we are out there to convince others. Do we have to convince others? I don't think so that we need to convince others. A new scientific truth will not triumph by convincing its opponents, but making them see light. But the whole thing comes because the opponents eventually die, and the new generation which is growing up with us, it become familiar to it. So people who learn from me, who people will see, they think this is the norm. They will not have even the thing to question why does it happen like that. And the quest for innovations is the need for the day, and us who decide whether we want to create something new, something which can be easier for the patient, safer for the patient, and comfortable for the surgeons. So the first thing which I want to talk is neovagina. That is when we talk about the biliary anomalies, the congenital uterine anomalies is associated with variety of gynecological and obstetrical problems. The goals of surgical treatment of uterine anomalies will be restoration of normal uterine architecture, first thing. Second, can we preserve the fertility? So whenever we look at what do the patient wants, they want the normal anatomy so that they can have a normal sexual life and common the thing. The second one is if they can preserve the fertility so that they can have a child. However, when it comes to biliary anomalies, the normal or near normal architecture cannot always be achieved. And merely creating an opening or normal ovarian cavity will not be therapeutic because the no vascularization, myometrial and cervical function can also be abnormal. So we need to be realistic and give them the real thing, what you're going to achieve and what we have to do in the other ways so that the fertility can be achieved. So what are the indications of surgical repair? When it comes to agenesis, our aim is only to restore the anatomy. So a vagina is absent, we create one. Cervix is absent, we create one. But the function cannot be restored unless we think of how it's going to be pro-oocyte or pro-uterine direction. So when it comes to other congenital uterine anomalies, the primarily it is directed towards the septa. Yes, if there is a septa, we can just cut it. If it's a bichordate, usually we do not do anything, but unless it causes a recurrent pregnancy losses, that's when we do a modification, modified. Either we do the unification surgeries or not. If it's an obstructed hemiuterus or ACUM, we again go ahead and remove the the unicornate uterus, which is the non-functioning or functioning obstructed hemiuterus. So when it comes to the unicornate or arcate, they're not necessary to do anything because that itself is enough and the surgery will not get the outcome. So we need to know where we suggest the surgery and what we suggest the surgery and what are the outcomes we are going to promise them. So let me stick to agenesis today because which belongs to the class 1 of anomalies according to ASRM classification. So it is about the around the 5 to 6 weeks of 5 weeks of gestation where this the formation of the Mullerian tract happens. So this results in the various degrees of agenesis or hypoplasia of the uterus, cervix, or upper two-thirds of vagina. So it can be a vaginal agenesis, cervical, fundal, tubes are combined. The commonest cause will be MK, the Muller-Rokitansky-Kuster-Hauser syndrome. So surgical repair, what we do is the restoration of anatomy. So with vaginal agenesis and agenesis, we have two basic broad thing where you have either pressure dilatation techniques or you have plastic surgical techniques. So pressure dilatation techniques are Frank technique where intermittent pressure technique is used, or Ingram's modification of intermittent technique where there's a stool, the cycle is pre-made where there will be a mold type of attachment there where the girl sits on it and does the cycling. So the intermittent pressure technique happens and the dilatation of vagina happens. Vitiati technique, which is so gross and grotesque, and where there's a nut which is placed on the thing and there's graded up pulling off it. Then you have a balloon vaginoplasty where a Foley's catheter is used and it is pulled above so that it can happen. And newer laparoscopic techniques are used, but the plastic surgical techniques are Abby McIndoe technique or modification of Abby McIndoe procedures. So timing, when should we do the procedure? Not just because you find it at 16 years you do it. You do it because around 18 years, because that is the time when the high estrogen levels are present, which prevents stenosis. And she is mature enough to understand the importance of dilatation and she can do the dilatation herself. So the surgical techniques will be Abby McIndoe technique, where the split thickness graft was used to cover the stent which is inserted into surgically created neovagina, or we create the modifications of McIndoe techniques where various adhesion barriers like peritoneum and skin flaps or amnion or buccal mucosa or bubble are used. There'll be a lot of side effects with it. If you are using a bubble, there'll be ulcerations if she has an ulcerative colitis that happens even in the vagina. Or if you're using a skin flap, they can have a grossly abnormal, the hair which keeps coming from inside, or they get infections of that. And if it is the amnion or anything, you can still have a section of the HBsAg and all the viral infections which can still come. So the modification which we have started way back in 2005 is the use of interseed, which is the oxidized regenerative cellulose. The principle is the presence of this non-adherent layer between the stent, which we give, the mold which we create, and the near vagina allows the epithelialization to occur beneath the gelatinous layer, thus preventing the adherence. So the OR times is only 10 minutes and the least morbidity and the comfort can be thing. So this is our publication which happened in the American Journal of the Minimally Invasive Gynecology way back in 2019. So let me show you the video of how it works. So there's a raphe which is there, which is actually the original cloaca, which is supposed to be there between the urethra above and the anal mucosa below. So on either side of the raphe, we give about 10 to 20 cc of the vasopressin injected. On either sides of the raphe, using the graded Hagas dilators, we just cleared the bride vagina at 45-degree angle, which is the normal angle at which the vagina happens. So we gradedly dilate the space which we have created between the bladder and the urethra above and the rectum below. You can see the assistant's hand, which is in between is in the rectum. So the raphe is then cut and the graded the speculums are then inserted, and the neovagina which is created is then deepened till the peritoneum above. So you have about 9 to 10 inches into the vaginal cavity which is prepared, and about 4 inches in the transverse direction. So you have a longitudinal opening about 9 to 10 and a 3 to 4 and the lateral. You can see how gradedly the sim speculums are being utilized, and you can see the depth at which the neovagina which is created can be seen. Hemostasis is maintained, and then we start preparing the mold. Before that, we intern the normal vaginal mucosa, which is then created from the vulval mucosa, and then this is interned inside, and then and then sutured using the 3-0 Vicryl rapid. So this interning will allow the epithelial membrane, which is now gross, and neovagina, the epithelialization is done in between this, the vagina which we create, plus the mold which we put it in that. So you can see the 4 sutures which we are creating. There. This is on the right lateral, left lateral, which is created anterior and posterior. The hemostatic agent is now put. Then that is the vipriatic mold, which is soft. So number 8, 8.5 glove is then taken. So one finger, we take either the thumb or the long finger. And in that, we have a Vaseline gross. Around 4 Vaseline grosses is what we need to create a structure which is having the length and the width of the penile architecture. So this is what is then tied. And a lot of antibiotic is then put, and again we have the condom which is then loaded onto it, which is again softer. Then small holes are then put so that there is no collection which is there. Whichever is collected in between is then comes out, and again it is created, and antibiotic is then put, and interseed, which is oxidized methyl cellulose, is now applied onto it. So there's no gap between the interseed and the mold which is there. So the mold is never adherent into the lining above. So now this mold is now inserted into the vagina which is created. Then the vulva is then closed above it and below it. The lady is kept in the hospital for 5 to 6 days, catheter in situ for 5 to 6 days. She'll be on liquid diet for about 2 days, and then soft diet is started. And once we start the soft diet, we don't want constipation, so chromafin is then added. So this is the end of the procedure. So now what happens next? That is what is more important. So doing is one thing. Then what we see is the result is afterwards is one thing. So the next is 1 week post-op. You can see the epithelialization which is created there. This is 1 week post-op. This is 4 weeks post-op where the sim speculum can go and the epithelialization is done. How are we maintaining? She uses the vaginal dilators 5 minutes 3 times a day with lot of estrogen ointment in it. So estrogen helps in epithelialization and thickening of the epithelial lining. So this is post 4 week post-op, and next comes the 6 weeks post-op where you cannot see any rugosities which come with the cusco-speculum goes and comes in. The ease with which the cusco-speculum can be utilized can be seen, and the pain is not there. So the ease with which she is maintaining the neovagina can be appreciated. So to date, we have around 71 cases which we have finished, of which 65 are RKS syndrome, and androgen insensitivity syndrome is in 6 cases. And the mean operative time is around 15 to 20 minutes, and vaginal length about 9 into 4 centimeters is what by day 8. 8.5 into 3.4 is at that 6 weeks. Now there is a broad width and the length. The ease of dilatation is seen in all 71, married in 24, and normal sexual satisfaction in 24. Take-home babies or through surrogacies of 2 babies, ongoing pregnancy which is going to deliver is another one. So ovarian rejuvenation, coming to the next technique, that is ovarian rejuvenation and endometrial regeneration. With regenerative medicine, what we talk is about it replaces or regenerates human cells, tissues or organs and restore the normal function is what we look at. So we include stem cell therapy, cellular therapies, tissue engineering, and gene therapy. So regenerative medicine has a potential to deliver new innovative therapies or even cure. That's what we are looking at. Are we giving them? But we again have to be very clear about what we are offering. Is it fact or fiction? So we are looking at rejuvenation where we are enhancing the body's ability to heal itself. So we one simple thought, when we cut ourselves, within a few days, the skin heals by itself, whereas other organs do not repair themselves so well. Why is it? So that's where the thought comes. And when we know that there are highly specialized cells which constitute the heart, lungs, nerve, they can remodel and possess the ability to self-heal, which is just give that impetus to do it. So the center, Regenerative Medicine Center, helps us to enhance the self-healing process. So replacement is when we replace the organs. That's when where we do a kidney transplant or a heart, or where we look at the lung and liver and so. So the center aims at overcome the donor shortage, a need for immunosuppression, and challenges with the organ rejection. Can we do it? So regeneration means, again, cell-based stem cells or cell products are something which we use, like PRPs or autologous bone marrow stem cells, or mesenchymal stem cell like bone marrow transplants, where we instigate them. So it regenerates the cells, and cell products help in the FDPs and everything, the regenerative growth factors to develop there, or new angiogenesis to happen there, or totipotent cells to stimulate the cells to change itself into a cell which can regenerate there, or whatever is hidden inside or expressed outside. So this holds promise for definitive, affordable healthcare solutions to heal the body from within. So in gynecology, regenerative medicine works at regeneration of urogenital tract, that is SUI, bladder reconstruction, pelvic floor reconstruction, vaginal reconstruction, fistula repair, endometrium, and intrauterine stem cell transplantations, or will help in thalassemia, inherited immunodeficiencies, muscular dystrophy in the future. So this is the paper from RCOG, which has come in way back in 2012 and May 2013, which still holds true with much more better offers. So when it comes to ovarian rejuvenation, we look at what is the AMH, which is more, which is less, which is going to be staying less. We are not looking at the what this thing she has, reserve she has. We look at what we can do to her today. So infertile woman, which has more than 35, low ovarian reserve, that is more than 12 FSH is what we look at, but their karyotype should be normal, and presence of one ovary at least. These are the patients who look at, and we correct the thyroid and prolactin which is there. This is a research paper which is published first in GRAFM, where preliminary study of this into the ovarian ovary and the endometrium. So laparoscopically, we hold the ovary and then instill into the ovary, and then into the endometrium is what we look at. So usually we look at 7th to 11th day, we do a laparoscopy. So here you go, you see how the streak ovaries are. Then we go towards the ovarian ligament and see, you can see the installation, how it helps there. Then pro ovarian ligament and pro infundopelvic ligament is where we look at giving the PRPs. Initially, we used to give only PRPs. Now we give both the autologous bone marrow stem cell and PRP into the ovary. We can just see how the volume of the ovary immediately improves, and the volume exponentially improves over time within 3 months. So in hysteroscopy, we give subendometrial, multiple punctures are made. And then when we give instill the stem cell into the uterus, just by sheer contraction of the uterus, the stem cells and the PRPs are sucked into the subendometrial region, where they influence the new angiogenesis there. So how do we assess the treatment? We check the endometrial thickness, we check the zone 3 blood flow pre and post-op, ovarian blood flow pre and post-op, hormones like FSH, LH and AMH are measured. Same thing is measured in day 2 of 2nd or 3rd cycles post-op also. So till 2018 December, we were doing only PRP, around 80 cases we did, and then we saw a huge amount of response, which started decreasing at the end of 2 years. So we looked at HE patients, POF patients, streak ovaries, poor ovarian reserve, primary, secondary infertility, thin endometrium per se by inassurance, TB endometrium, septal resections is what we had the patients. So endometrium improved in 35 out of 15. 15 it was same because it was good even before. So improvement done only in thin patients is about 13 out of 16. In zone 3 blood flow is improvement is seen in 42 out of 50. Which cases we did not get good result is grade 3 Asherman's and tuberculosis to the core. So OI going on, ovulation indicators went on in that, and most of them had shown good pregnancies. About 11 pregnancies we had given out of these 80 patients. 8 patients had delivery, and then with abortion was there in 3 patients. So when we had these babies and the ongoing pregnancies, we realized even the goal was only pregnancy. What we saw is the very good response in the form of hormonal changes. So the premenstrual syndrome or perimenopausal syndrome, and the outcome was very, very, very good. So then we started doing from the January 2019 autologous bone marrow derived stem cell therapy. This is our first publication way back in 2015, which we did in congenital endometrial hyperplasia. Our good news is that right now this girl, a teenage when we had done this in 2015, now this publication was in 2016. This girl is right now married and she's now carrying pregnancy. The case where endometrium was completely absent, we generated the endometrium and she got married. Now this girl is pregnant with IUI. So this is our next publication, which happened in 2021 about the autologous bone marrow derived stem cell in the endometrial and into the ovarian rejuvenation. So after that, we will go. The aim of the study was to check again the endometrium and check the FSH and everything. So in this, we had only 37 symptomatic patients apart from the 80 which we had. The same inclusion exclusion criteria were utilized, and just the way we had showed in the laparoscopy, we did the thing. But activation of PRP was done with calcium gluconate just before instilling into the laparoscopy and the hysteroscopy. And this is the way the video, when we see, you can see the endometrium, which is very thin. And here you can see there was no endometrium at all, literally. It was a thin out fibrotic endometrium, which you can see, where multiple punctures are made again subendometrially, and then the stem cells was given. And the post endometrium, you can see how the endometrium regenerated even in the ultrasound picture. So the stem cell is being given here, instilled into this by using the IUI catheter under the ultrasound guided, where we do only the endometrium. And you can see the blood flow, how it starts improving. So no adverse effect at all. And all the patients are evaluated in T1 at the beginning of the study, 2 weeks, 1 month, and 3 months. So as of today, what we did until May 2022, around 68 patients received the stem cells and PRP, primary infertility in 30 and secondary infertility in 22, postmenopausal 2 women, premature ovarian failure in 11, poor ovarian reserve in 23, thin endometrium 11, Asherman's 10, post-radiation therapy for the gestation, trophoblastic tumors, and in 2 patients. And into the ovary, we had given only into the ovary in 10, and into the endometrium in 14, both into ovary and endometrium in rest of the 44 patients. So age less than 30 were only 24 patients, but more than 41 were 34, and majority of the patients were in 31 to 40 years of age group. And both PR, like I said, in 10 patients only into the ovaries, only endometrium in 14, and both ovary and endometrium in 44 patients. So improvement in endometrium at the end of 55 is seen in 86%, and total patients improved when it came to 100% improvement is seen by the end of the 3 months, even in grade 3 Asherman's. And so only few patients we did not see grade 3 flow, that is in grade 3 Asherman, and 2 patients, but otherwise endometrial thickness, endometrial receptivity we should see in 100%. So improvement in blood flow in day 15, we can see in 56.3, no improvement in 43. Day 30, we could see almost, this is an ovarian blood flow, improvement is in 29.3%, and no improvement in blood flow in days, but even though the FSH showed improvement. And the same patients, and we go ahead, FSH levels, when we take into it, we have seen improvement in 47 patients out of 54, that is 87% improvement. No improvement in 3. Which are the cases we did not see improvement? Where calcification is high, where the ovaries are calcified. This is where in postmenopausal women we did not see improvement. So mean FSH values have come down from 32 to 10. Half the patients we had 34, 64, 100, 82 also. In primary ovarian failure, we did see improvement is all 100%, and patients which we could see is into the endometrium, and we had given, like I said, endometrium improvement is in 50%, no improvement in 8%, 2 cases of septal resection and 6 patients of Asherman, we did not see improvement. Blood flow improvement in zone 3 is 33, 8% did not see much more, had the same normal, and improvement in 9 out of 2, that is 2 did not have improvement. Into the ovary in 54, and spontaneous onset of menstruation is seen in 4, no improvement FSH in 7, and ovarian Doppler improvement is seen in 16. Rest of the patient, even though they did not show improvement in Doppler improvement, we could see the FSH improvement in all. 4 patients needed second sitting, and 1 patient was 54 year, and you could see the pre-op 63 coming down, FSH coming down to 8, and 31-year-old, the results were much better, where we had only PRP before, we had given others, and she had pregnancy and delivered also. And again, you can see here from 33 to 4 was the change after we had given the autologous thing, and that lady had twins. So pregnancies total we had in 12 patients, 3 had missed abortions, 9 delivered, and 3 patients delivered had pregnancies after the second sitting. So discuss about it, like, degenerative medicine, we should try and try, otherwise she does not have any improvement, any choice. I think this is an thing which we can give the option to her. And then bone marrow stem cells are the same cell line as that of the endometrium and the ovary, and adult stem cells, and then also isolated from them and then given into them. So we had lots of studies which we had before, which people led various studies in individual stem cells. And then we could see this is something we have to understand. Aging of the niche is very important. So it is the anatomic microenvironment. If we change number of oocytes which we had already been destined previously when the girl was born is there. They're about 40,000. So what happens to the rest of the things? Over the years of this thing, hardly 350 is something which we use. They're inside. The anatomic environment is something which is not allowing these oocytes to come out. So we are changing the anatomic environment so that it becomes receptive for the cells which are hidden inside to come out and start coming out. So we are seeing that the local environment makes a fundamental role, and they're giving the ability of the adult stem cells to produce a variety of cytokines, chemokines and growth factors. So they can develop the growth factors, and the cells which are hidden inside then come out. So the bone marrow stem cells induce the in the endometrium. They cause the endometrial proliferation by engrafting. So since then, many studies have come up which shows that yes, the improvement is there, we should do. So the first question which people always ask is cellular therapy for ovarian regeneration effective? Yes, you can see the results that it is significantly effective. Yes, we cannot promise 100%, but menopausal syndrome is seen in 100% reduction in menopausal syndrome, even though the pregnancies and deliveries is not 100%. So why is there ambiguity in that? I think the technique, not just the technology, which is important. So that's the reason I keep telling people what is important in endometrium is giving it subendometrially, and what is important in the PRP is then going into the stroma and giving it more into the pro-ovarian and the pro-infundopelvic direction. So it's a technique and technology which is important, not just the technology. Which patients have best results? Patients which do not have calcification and who are not nearer to the menopause. So age definitely has a thing. So younger patient will have a definite outcome, better outcome. So main consideration with PRP, it gets coagulated very fast and we need to activate it. So just the presence of PRP is not important. You activate it with calcium gluconate just before injecting is important. And the timing of activation is important, just before giving it. And giving it into the cortex is what is very important. The timing, I usually give just after the periods are done. And if necessary, we can give a human growth hormone, which really improves the number of the preantral follicle from the primordial ones. And aromatase inhibitors to suppress the estrogen and lock the negative feedback also has shown people good results. So later stage, we can also add gonadotropins to the patient for her to conceive. So is there a patient with low AMH? I don't think we should be holding the AMH to task. Leave the OMH. Who is bothered about the reserve? We need the 360 oocytes which are supposed to be destined to ovulate. That is what is important for us. So what is important is that what are hidden, please come out. This is what we are looking at. So change the local environment. That is what we look at. So does it work for every single woman the first time around? Not necessary. Like I said, we had to do in 4 patients or 8 patients second time. So what we have to do is that try till we succeed. Give the choice to the patient. You do not decide for them. So what is very important, 80% of the time it is the antral follicle counts which improve, and that is what is important. So menstrual cycles are restored spontaneously in primary ovarian failure also. So it's very case based. So let us not decide for them. So can you do stem cell PRP regeneration in someone with 0 AFC? Yes. AFC might be 0. They are hidden. give it to them. We look at primordial follicle, not the Graafian follicle. So please do not even look at that. We are not looking at here any preantral follicles. Just give it primordial figure thing with the environment, becomes preantral, then becomes antral, and that's how the whole ovulation happens. Give it 3 months time for the thing to become. So what about the quality of oocyte which are obtained by that? They're again case-based. We did have majority of patients getting back the good quality, and IVF centers are very happy, and the specialists are very happy with the quality of eggs we get with that. So now we get lots of patients coming from them saying that quality is not good, madam. Can you do the procedure? That's how we do it. So science is something this we have to discover the unknown. Stem cell field is still in its infancy, but we have a head start. And how can you help this face that direction? So I think what we need to understand in cases with POF, low AMH, high FSH, poor oocyte quality, try giving them their own biological child. So endometrial regeneration is where we give the hope for the woman who has only the option of surrogacy. So use of PRP and stem cells has a vast scope. And I think these are the burning topics which people can't start arguing, but imagine a world where people can start giving them with their own. To conclude, so this is a game changer. I think people have to start thinking out of the box, and we have to give all of the patients to heal by themselves. So what is the potential to heal the damaged tissues and organs, and offering the solutions and hope for people who have conditions that are beyond repair? So advances in developmental and cell biology and immunology and other fields, try to just incorporate them into something which is clinical here. So don't just allow the two fields to be running like a parallel track in the rail. Try to join them. That's what we are here for. So it is the fusion of the biotechnology, engineering, and the medicine. That's where we can do it. So there's a single light of science, and then to shine it anywhere is to shine it everywhere. So let us start using it to shine it in the human being. So thank you, Dr. Prabhu, for giving me this opportunity to talk. And any questions, please?
It was a great presentation. And people who are in this field of regenerative medicine, we see it as lemon pearl, because there are many kind of a variation where people tell our PRP is superior, but you told it is not the only the process. The whole technique should be unique.
Yes.
I have a few questions because my students used to a message us on the WhatsApp.
Yes. Please.
So before coming to the participants' questions, so the first question is, what is making you to think unique? This is from my side.
I think when we start, instead of being so bookish, and then we have solutions in the textbook, which we are going to give to the patient, which has a different problem. Means in our brain, we have decided that fibroids, example, if I say fibroid, the treatment is this, and the patient has some other symptom, we still want to put this same solutions. Means you have a square problem, you're trying to give a round solution. So please understand the problem. She has a round problem, give a round solution. So you don't have a textbook solution. Think of a solution which can fit to the problem rather than giving the solution which is not fitting to the problem. So when you start thinking like that, that's when the solutions come by its own. So if they're not there, you have to think out of the box and come up with solution which is for the need of the patient, not our need. That is not our pockets need, or what, because our hands to be honed, or we know this, so let us give it to that. So I think it is always should be patient centric. Safety of the patient should come first. Comfort of the surgeon should come second. And basically it has to be the ethical way of doing the right solution to the right problem.
So I think when students have a bigger opportunity where they can put their thesis, they can do multiple research.
Yeah.
So, but they have to have the extra thing to go.
Yeah. Instead of trying to say, yeah, somebody has proved a formula, let me come up with 100 cases to prove the formula to be right. Formula is always right.
Yes,
why do you have to get and do the thing and get a PhD? That is not you guys have to do. It might be difficult. See, when I did my PG thesis, my topic was radionuclide HSG for infertility to know the functioning of the fallopian tube. That was the first in India. Nothing before, nobody done before, no nuclear medicine. I went to nuclear medicine, guys, I said, I want to do this. They're like, nobody, there was nothing, whether we had to use technetium pertactinate, they did not know. Whether to do sulfur colloid, they did not know. I was like, what is cheaper? What can be used? Then they came up with say sulfur colloid is cheaper. Then I said, I'm going to use sulfur colloid. Then we never knew how to read the results. So we started reading the results. Then we came up with that. So first time in 1997, 98, we came up with a thesis first time in India. We presented a nuclear medicine conference. We got the best paper anyway, naturally. That's a different story. But then again, after that, for a few years we did it. Then when we had so many laparoscopy, hysteroscopy coming up and everything, then we stopped that. So we should be knowing, thinking that how to come up with something. Just because there's a lead pipe is open, is open. But is it functional? Fallopian tubes are open is not enough. What is important? Here we have, just like your students, we also have students here. We are ready to trouble me here. So what is important is being open is not the thing. Being functional is important in human being. So the tubes have to function. They have to go towards the egg has to go towards the fallopian tube in the first. The sperm has to go towards the ovary first. Once the baby is fertilized, the function has to be sending it back to the uterus. Means function is different in different times. So what is important is fallopian tube function rather than anatomy. So I think people have to start thinking like that.
So,
or maybe I'm genetically abnormal inside, that I have been screwed in a different way. That's it.
so I'm going to put the question again. How to screw differently again? How to re-screw the brain?
I think
What makes
everybody,
the brain to, I think, like different way?
I think everybody has that. But conventionally in India, what parents try to tell is, don't ask stupid questions. Don't ask things which we cannot answer. Don't make a fool of yourself by asking. Don't get up and ask a teacher which people will start looking at you as if. I don't think there's a stupid question at all. It's a stupid answer only because we cannot answer. So once we start thinking like that, everybody has a zeal to know so many things. Everybody has questions.
Students nowadays are so hesitant to ask more questions also.
Because they feel people will look at them as if they're idiots. No question is wrong. True. It's the answers which are stupid, which are idiotic, because we don't know how to answer. That's it.
Excellent, man. So again, this is from one more PG also. What is driving you to do more?
I feel that his one life. If we cannot do now, it's okay. And we really are not at all. One thing which is very not constant, or which we cannot predict, is whether you are going to be alive tomorrow or not. Also, nobody can predict what is going to happen next second. So in whatever time we have, we have to do what all we want to do. So I think that is the only engine which pushes me. And for me, I think adrenaline rush comes from the brain. So if you don't activate it, one disease which always scares me is Alzheimer's. And I don't want to have that disease. So I keep it activated. That's it.
Good. So they're asking, what are the skill sets which are the students while learning, no? So they should acquire.
So I think first thing is,
FPGs.
Yeah, all of you have to understand there are a few questions which you have to ask. Why, when, what, how? These are the questions which you all have to ask yourself, first of all. If anything is happening, why is it happening? How is it happening? When is it happening? And what is making it happen? If you start asking these questions and if you don't get answer for anything, start searching for that. That's one thing. And for me, there's another mantra also, which I tell my students. For anybody to be successful, there are some things called, first is technique. So if it is a technique, you have to master the technique. You keep on learning the technique, whatever you have to do. Second is technology. Technology keeps changing. You have to upgrade yourself. You have to learn the technology, and don't use the technology just because it is there and it is expensive. Use the technology if it is needed and make it cost effective. Third thing is team building. Nothing is me, myself, me, myself, me, myself. Always it's a team. If everything process which you have put in place should run even if you're there or not. The fourth one would be training. Unless you train yourself properly to do those things, you will never, means when you start getting training, you get honing your skills more and more. Recurrent, repeated activity is something which makes you a master. So nothing happens once and second. And then fifth would be teaching. Whatever you have learned, unless you teach others, you will never become a master and you will not be calling whatever you want to be. Finally, I feel, which is again, I still have to learn that point, which I'm not great at, is temperament. Okay. I get angry. I'm human. I shout at people, but still people take it because I have already achieved something. So they are taking it. But when you're raising up the ladder, if you have a bad temper, you will never be able to raise up a ladder. Saying all that. And I also think that for a ladder, or to use somebody as a ladder and come up, it's always good. But means I'm not trying to tell you about the mentor protege thing. You should have a mentor, but it's your fate who will tell it's a good mentor or a bad mentor. And your mentor is what will make you whether whatever, because you are going to climb up that ladder only looking at that.
Understood. Understood. And when did you think of a regenerative gynecology?
So let me tell you about this. I think regeneration started in 2015, like I said. There's this girl who is right now pregnant. Huh? There's a Muslim girl who came to us who got birth father after they've been tried everywhere, primary amenorrhea. Now, in their culture, very important is the pregnancy and delivery. That is very, very important thing. And this girl is there who is not having menstrual cycles at all, primary amenorrhea. There's so many reasons for primary amenorrhea. We evaluated that, everything. And luckily for us, I would say it is lucky for me that she had a uterus intact, ovaries are fine. She does not have anatomical abnormality and all. Only thing it was lacking was the endometrial lining is completely absent congenitally. Then we started doing research. We were doing that and this. And then I spoke to the parents. I said, there is this thing which I want to try for her, but nowhere it is done. Can I do it? The parents are the one, only with the consent of the parent. They said, just do anything. We trust you. That's the first time. Then I spoke to our hemato-oncologist who was doing a bone marrow transplant that time, called Dr. Sailesh. Then both of us together thought of doing this. Then I did a hysteroscopy and then we did that procedure, what I showed you. Now, within second minute, the radiologist, again, she was my friend, Dr. Madhushri. She had done the scan before. Then I sent her after 6 weeks. She was so excited. She said, I can see endometrium, which is moving. I can see the blood flow there. And she was so excited from the thing she started calling. I said, don't worry, relax. Then that's how the endometrium, and she had regular cycles after that. That's how the first thing came. Then we started using PRP because we were worried about using it in the ovary. Now, when we did our research and when we published, we knew that bone marrow stem cell is in the lines with the endometrium. So that's fine. It's going to work. Now, ovary, we were not very sure. Then we were using a lot of PRP because it is something which can be just used in both ovary and then we were seeing good results. And then, but the results were only temporary and they were just faltering at the end of 2 years. Now we were thinking what to do, how to do. And in that time, we had this one conference for vaccination thing in Lisbon, Portugal. So when I went there, we were 4 of us representing India, one oncosurgeon, me, and one from Delhi, and another, I think a gynecologist only from Calcutta. So
Which
this
year was it?
2015, okay. Lisbon. Okay. So when I went, then there was a discussion between me and an oncosurgeon because his daughter was having an issue. I was telling him about the PRP. Then he was like, is there anything else we can do? Why can't you, when you did that, why can't you do this? Then I said, this lining is there. And then the ethical and everything comes. He said, you should be doing it. And we came back. Then we applied for the ethics committee, local ethics committee with us. It took us a long time to convince them. And we put the other collaborative things because there are already bad results coming from the brain and everything about stem cell. Then we told this is the same line and it is the autologous, so ethics is not needed and everything. But then they gave the clearance. Then we started doing this thing. And then the way the results started coming out, we were, I mean, there's nothing stopping us from them then. That's
so
how
everything. Good. And
last
how
one
do you
or
manage
two questions?
innovation? Yes.
Last one or two. I have to eat also.
How do you manage innovation amid your busy schedules? Because mine has to work.
Like I said, there are two things which really help me. No, I have two things. One is my team. Okay. They are with me. They'll do whatever I say or it is, they manage and everything. But the second is again my temper. I will not have pent up anger inside. I give it off. So I tell it out, so everything comes out. So I don't have to think about so many other things. Did I shout? Did I do? I don't. It's over, closed chapter. I don't carry anything forward. So if I shout at somebody and again start thinking, ayyo, I shouted at them, ayyo, I have to pacify them, that doesn't work. They also know if I shout for a purpose and it is a mistake they have done, they correct it and I never carry it forward. And next it will be as another. So I think I just give it back and then I think that allows me to think again and again discuss with them.
So keep your mind free then.
I'm free of all these conflicts inside my mind. And
people think in the early morning, picking the new ideas.
Early morning, I only work, operate. My ideas come in the sleep and the night. This is absolutely true when you said I hardly actually, I'm a night person. So, okay, in this, I'll just tell a small anecdote. When we started laparoscopy way back in 1997, and we were doing it, so suturing was the only thing which was difficult for us. So in laparoscopy, I have a lot of newer things which I have started, including the obstetric reports and everything. So when we started doing suturing, it's always the men's way of doing it, and ergonomically very bad suturing techniques which were they thinking, and they were always arguing that this is the right thing and all. So whenever we used to try, it used to be bad. So one day, next day, it was in myomectomy. I went home. I was thinking in the thing, and something in the dream came where I was doing a suture in a different technique. Okay, I did not say anything. Came back here. I had a technician called Kayum and a nurse called Swarna. I told all of you, don't talk. I'm going to do one new thing to do suture. You listen, you see. So then we did a technique of a wrap technique, which is now everybody knows that. So wrap 1, wrap 2, hold and pull technique. First time we did way back in 1990, not 98, 2003, I think we did that thing. So it is like that. Suddenly it comes how to do it, without thinking how to do it, some solution comes up. So I think I'm a night person, and night it happens.
Yeah, this thing is happen for many scientists. They get dreams. A benzene ring, it came with the dream for a scientist.
This
You can put multiple
suturing,
things.
this happened in dream for me.
Maybe you're
Like
blessed.
Maybe I'm God's favorite child, I keep telling people.
True. So there is no second thought in that. So because we are running out of time, one important question, people asking me again, can our PGs visit your place for any training fellowships?
Absolutely. They
Can
can
we have exchange program with our hospitals?
They can come. I'll share with you one of my assistants' number. In fact, many of the doctors keep coming. This is Care Hospitals, Hyderabad. We have so many gynecologists who come that one day, come morning, see the procedure, see how we do that and go. So you can coordinate with
We want a kind of a MOU where our people can do a research.
Okay, then you can coordinate. It is possible to do research also. So we can have an MOU with our ethics committee or with our hospital administration. Dr. Sindhura's number I'll share with you, Dr. Prabhu. You can coordinate. We can do that. Okay.
Thank you, madam. Thank you, madam.
You. Bye.
Bye. So thank you, everyone. I want to thank this time management and the speaker and the participants. So once again, we'll meet you with the next program. Thank you. Take care.